thank you, Kevin, for joining us today. And we're very excited to have you part of the two-day introduction to early intervention postural orthodontics in Newark on the 27th and 28th of September. We're looking at bringing together an integrated approach where we had pediatric specialists, where we had orthodontists, ear, nose, and throat surgeons, and of course, the bulk being primary care dentists. We are trying to figure out how to connect the dots. And one of the things that I've always admired about you and your work is your broad view on how to do more than just be a children's dentist, a specialist children's dentist. You've somehow, over many decades, acquired the skill to guide various groups to connect together so that they can take care of the child holistically, not at the point of each specialist focus, but working together so that that child from cradle to the grave is taken care of and becomes part of each of our families, career families. We thought, okay, we'll get an orthodontist, we'll get an ENT surgeon, and we have to have a children's dentist. Of all the children's dentists that I've actually known in my career, you're actually the first person that I've spent any time and connected with. And that was like maybe 15 years ago in California with one of Bill Hang's programs. It's such an honor that you are going to share your wisdom and hopefully bring some enlightenment to these primary care dentists in their role in the medical health as well as the orthodontic health of these children. I know you've got a few topics that you want to spend some time going through. I understand one of them is an awakening of a 72-month timeline in the growth and development of a child's jaws. Can you give us a quick insight in what you mean by the critical time zone of 6 years of a child's growth in their jaw development?
Yeah, Simon, it comes from the American Academy of Pediatric Dentistry's policy on getting early childhood caries as into the International Classification of Disease book, ICD. At the time, it was ICD-9. It's 10 now. But a lot of kids had tooth decay before the age of 6 years old, 72 months old. That defines what we mean by early childhood, before 72 months old. And that's what defined early childhood caries. Well, it was mainly because insurance companies, if kids had to go to the operating room because they were too young, it was too much for them to tolerate while they were awake. Sedation in a dental office isn't necessarily the safest thing to do for a child's airway. So we would have to use tertiary care hospital operating rooms, and the anesthesia costs would not be covered. The medical insurance, oh, that's a dental problem, we're not going to pay for it. But when that classification, and it was Art Noack and Paul Casamassimo primarily in the 90s that came up with that, maybe sooner, early childhood caries. It's a definitive diagnosis. And we're saying early childhood malocclusion. There should be a similar nomenclature for malocclusion that will not self-correct. When you see transverse deficiencies, when you see sagittal deficiencies, when you see vertical excess or deficiencies, like in a gummy smile, those are things that will not self-correct, as you cited Peter Bouchang. By 6 years old, if you got a vertically growing jaw, it's not going to get less vertical, okay? And transverse deficiency with or without a crossbite, same thing. And there's metrics you can use on a frontal ceph or measuring at the lingual surface of the upper primary second molars, the Bogue index we call it, and mandibular retrognathia. You can see it in utero. You said cradle to grave. How about pre-cradle to grave? These things we hypothesize show up on a mid-gestational ultrasound, at least the mandibular retrognathia does. And that's something that Christian Guilleminault was curious about. So that's really where that comes from, Simon. I'm glad you brought it up.
Oh, that's a topic that I think is very vague for most primary care dentists. So you explaining it and teaching about it is going to be of good interest. Those early childhood primary dental skeletal malocclusions, how do they impact medical conditions, do you think?
Well, wait, that's another thing we're going to be talking about at the AAPMD Collaboration and Cures meeting in Reno next month. Loria Najadas is a pediatric dentist in Dallas, and she and I are doing a 90-minute program talking about those three types that I just mentioned in the vertical, transverse, and sagittal dimensions that are frequently comorbidities with sleep and breathing disorders. We don't say they're causal. We just say that they coexist or they are comorbidly associated with sleep disordered breathing. And sleep disordered breathing can lead to pulmonary hypertension. It can lead to neurocognitive and neurobehavioral problems. It can lead to hearing loss. Quality of life is a validated metric for a child's health quality. And lots of kids, even with just maxillary expansion, there's several papers now published of how general health and quality of life of children, under age 6 or older than age 6, middle childhood, late childhood, early adolescence, that maxillary expansion alone in the presence that implies, that there's transverse deficiency will improve these children's quality of life and general health. And they cite specific traits such as hearing, such as neurocognitive and behavioral, better sleep, better attention, and pulmonary, cardiopulmonary index, CPI. It's a new metric that's being used. So lots of things relate. These are all interrelated things. What we do know for sure, some of these kids, they don't have obvious sleep and breathing problems or cardiac problems or hearing problems. Well, you know what? So what? The malocclusion will not self-correct. That is the thesis upon which we base our whole protocol, is that often these things are obvious or they will become obvious later. Highly likely that they will if the malocclusion is not appropriately addressed in a timely manner. So the malocclusion will not self-correct. You don't let it get worse any more than you would let a kid who has high myopia, nearsightedness, at 4 years old. You would never tell a parent, let's wait till he's almost blind before we start correcting his vision. Okay? And that's really the orthodontic paradigm, is let the malocclusion get more complex. And then we'll try to do what we can. I say that's a word that starts with bull, has an S in the middle, and it's not bullseye. I want that to change.
Absolutely. You've also been a strong advocate of a preventive mindset in exploring oral dysfunctions and masticatory incompetence. Can you talk a little bit about that?
Well, you brought up ontogeny, cradle to grave. That's just what happens in a single generation, which I say possibly, during preconception, but these problems are in the, they happen to genes being manipulated by the environment. But there's another term that I like to introduce because of my anthropology. I'm an anthropologist in training. I'm not an anthropologist. I don't have a PhD, but I'm doing postdoc work with Mariana Evans at the University of Pennsylvania. You know that. And also at Arkansas with Jerry Rose. But there's a thing called phylogeny, and that is over several generations what can happen. And what has been true of all hominin species, we call them hominins, Neanderthals or Homo sapiens, we're hominins. Chimpanzees are not hominins. They're primates. We're all primates. Well, what I do is I go back to the hominin when it starts and when the genus Homo starts. I used to say it was 2.4, 2.5 million years ago with Homo habilis or Homo erectus. It's actually before that. The use of stone tools started over 3 million years ago, and probably limited use of fire as a tool for pre-digestion of food. They used fire and tools to help pre-digest tough foods. but they were still tough. And we spent our whole existence in search of these foods, hunting and gathering these foods, and then chewing these foods. And brain size is inversely related to tooth size. Our teeth were huge, and so were our jaws. As we discovered fire and how to use it, and tools, how to process food, how to take down big prey, we had better quality nutrition. Most of the nutrition that took us all day long to chew was low quality. It didn't have many calories or proteins, but we needed to eat a lot of it, and it took a long to biologically process it with our big teeth, our big jaws, our muscles that connected higher up on our head. We used to have a big crest up here where our masseter and temporalis, the muscles were much longer, and more work is done with the greater distance. Well, what happened, Simon, as we discovered how to pre-digest food with tools and fire, our brains started to get bigger, and our teeth started to get smaller, and our jaws started to get smaller. And we call that in allometric scaling. They did it in proportion to one another. So even though the jaws got smaller phylogenetically over thousands of generations of hominins, until about 300,000 years ago, Homo sapiens appears in Africa, our jaws were smaller, our teeth were smaller, and our brains were huge. It's like 3-to-1 difference in tooth size from a Homo erectus between a Homo sapiens. Okay, well, that was fine. And then agriculture comes in about 12,000 years ago, and boy, we could process that, and the foods were even softer. So our teeth got even smaller, but so did our jaws a little bit, in concert with one another, allometrically scaling, proportionally scaling. Then you know what happens. We discovered the steam engine, what started driving looms and, the textile industry and the Industrial Revolution, women leaving the home. They were the first workers, foundry workers in the textile mills. They abandoned hundreds of thousands of generations of hominin nursing and weaning on demand. They had to give that up. Wet nurses were created. Infant formula in infant baby foods were created. The advertising was they're for invalids and infants, meaning babies can't chew. They shouldn't chew. Oh, really? They did for 300,000 years. They chewed hard food. They baby-led weaned. Okay? And they nursed on either their own mother or was called an allomother, another mother in the hunter-gatherer tribe that was lactating, and the other mother, maybe she wasn't lactating or she died. People helped raise each other's kids. But one thing that was consistent, Simon, that they had to chew, chew, chew. In fact, what does a myofunctional therapist have in common with a trained? They both say chew, chew, chew. Okay, that's one of my kid jokes or a dad joke. But we had masticatory competence. If we didn't have ideal, optimal masticatory competence throughout childhood, guess what, Simon? We didn't live long enough to develop malocclusion because we didn't survive childhood. Nobody in the skeletal record beyond maybe 600 or 700 years ago, very seldom will you find any appreciable malocclusion, because nobody would live to be an adult and reproduce if they didn't have optimal masticatory function in early childhood. Those kids died, and they died with perfect teeth and jaws because they wouldn't live long enough to develop a malocclusion. That is a hypothesis I've developed with Rob Corricini and Tim Bromwich at NYU, both and Jerry Rose at Arkansas. So what's being left out of our curriculum, and you know it, Simon, anthropology. Yes. I have a book that was written in 1953 called The Masticatory Apparatus, and I got it from the American Dental Association. I checked it out. It was in their archives, and they said, Dr. Boyd, you don't have to return this, because since 1953, when we got this book, it has never been checked out once. This was two people's attempt, Klatsky, his name was, trying to get dental anthropology into the curriculum. They were unsuccessful. So maybe that's another thing that will be an offshoot of what the American Dental Association now is doing with their task force, what you are doing, Simon, what Amanda's doing, what we're all trying to do. We have to change the way pre-doctoral students are taught. So primary care dentists are coming out, understanding these relationships. I could go on, and I have too long, so I'm sorry.
That's a perfect insight in what we can expect from you in Europe. So we're very excited to learn from you and to share in your experiences, and it's such an honor, and we so look forward to seeing you there in our program.
Likewise, I'm really looking forward to this, Simon.
That's wonderful, Kevin. Thank you so much.